Hi, welcome. My name is Terry Brame-Joy. I'm the Director of Clinics here at Encounter Telehealth. And this is some documentation training that we've been needing to do and that we're going to ask all providers as they come on board with us, and then probably annually to walk through some type of training like this just to keep everybody up to date. I've done brief audits of a few charges, few notes for charges, and I've seen some areas where we could definitely improve documentation. Unfortunately, we don't have any providers on today, so hopefully I'm going to get some good email questions back as you watch these, because I always like these trainings to be a dialogue between the providers and I, because of course you have the clinical experience and my background is the documentation and compliance. And so we both bring something to that discussion on how to find solutions where you can treat the patient the best and we can also follow all the rules we need to follow. I'm usually can be pretty creative about making sure we stay within the rules that we need to follow, but also making sure to minimize the effort you need to put into documentation. Just a little bit on my background, so you know I'm not just making any of this up. I've been in healthcare management for 17 or 18 years now. I started as a surgical coder at the University of Nebraska and eventually went into both compliance and practice management at University of Washington, Cornell University, and my most recent position was as compliance officer for the entire practice plan at University of Arkansas before I came on to Encounter in 2016. I'm also the author of the only evaluation and management services textbook that's on the market now for coders. So I've spent way more time with these codes than I think anyone should. I estimate that I've either coded or audited around 20,000 E&M services in my career. I also had the benefit of at University of Washington of coming in after they had a whistleblower lawsuit with the OIG and helping the university work through a corporate integrity agreement with the government. So I unfortunately know really well what they're looking for. So 2 goals today. 1, I want to minimize your risk in audit and minimize Encounter's risk of having to pay back for services, but I also want to maximize your revenue. If you look at a graph of those two, there's a point at which the 2 goals intersect, and I like to get you there. I don't want to be collecting more revenue than we should at that higher risk point of having to give it back, but I also hate leaving any money on the table that we shouldn't. So those are the goals today. Hopefully this will be helpful. And again, I'm really looking forward to hearing your questions and feedback after you watch this. Our agenda today is we're going to talk, of course, about the psychiatry services codes and then the evaluation and management services that you use. We'll talk a little bit about prolonged services and behavior change interventions. I have a couple of codes in here to talk about that we don't bill a lot that I think maybe we could, and even though they're low dollar, if we do them a lot, that eventually adds up and it can make a difference. It often, really can add to a margin. So we'll start with the psychiatry codes. Just a reminder that all providers can bill either 90791 or 90792. The difference is that the 90792 has med management involved. If you have a patient who you end up and do a diagnostic eval with that doesn't need medical services, you would certainly, medication services, you'd certainly just bill the 90791. In the nursing homes, if we start seeing more patients for annual evals or they have some minor symptoms where maybe the medical director wants the patient seen and they have some more minor complaints that maybe don't warrant med management, it may be more appropriate to use that 90791. Now, yes, it reimburses a little less, but we want to make sure we're billing the appropriate codes for the work done. We often work backwards in how we should select codes. We decide, okay, well, I'm a psychiatric provider, so I bill a 90792, so this is what my note needs to look like, and this is what the service needs to be to get to that code. And really what you should be considering is that the code is the endpoint. Provide an appropriate service for the patient that you're seeing, document that service accurately, and then select the code that represents that documentation. So try to work forward from appropriate care rather than what ultimate code you want to bill. little bit of a difference in how you think about it there. So give that some thought. The exam that's required in the 90792 is a comprehensive 1997 psychiatric exam, and it includes everything on this page. At any point, if you want to take notes, you're welcome to pause the presentation and write things down if you want here. I also am going to put together not all the slides, but an actual more helpful handout that goes with this presentation that you can use. That will include this comprehensive 97 guidelines exam for psychiatry. Notice that we do need 3 of 7 vital signs, general appearance of the patient, and probably the number one thing I see missed most often in our notes is musculoskeletal. Obviously, you're not touching the patient, so you're not assessing them in that way, but certainly you can make note of one or both of these, their gait and station, if you see them walk in the room, or, you know, are they able to hold their head up, that sort of thing. There's certainly some assessment you can appropriately do there to include that piece. So I would say that's the number one thing I see missing from our notes right now. Also remember to use these diagnostic evals for reassessments in the nursing homes. If you have a patient that goes into the hospital and comes home and they've changed all their meds around, or they're on some new meds, or the patient has had a change in mental status due to an illness, and you need to, you know, actually reassess that patient, it is absolutely fine and appropriate to reuse the diagnostic eval. That isn't just the first time you ever see the patient and then until the end of time you can't use it. It is for the purpose of diagnostically evaluating the patient psychiatrically. So keep that in mind, that, you know, sometimes we kind of call it the new patient or the assessment code, but use it when it's appropriate. Can't bill any counseling or any other E&M services with this code. It really is a large bundled code, and that's all you're going to bill on that day. You also can bill it more than once for when separate diagnostic evals are conducted, but this code also includes if it takes you more than one visit to complete the eval, we would only bill once for, let's say, both of those visits. So I know one of our providers at the clinic had that happen where they weren't really able to finish the eval in the first visit. She had the patient come back the next week. They finished that up. That really is one diagnostic eval that's billed as one service to come to that diagnosis and decide on some therapy. This is a code I never see used, and I think maybe we're trying to build interactive complexity in other ways by either using family psychotherapy or prolonged services, some other things. These codes can be used specifically with the psychiatric codes, excuse me, so they can go on both the diagnostic evals and any of the therapy codes, any therapy add-on codes. Any of those, the 90791, 90792, 90832, 3437, those codes, when one of these situations exists. So maladaptive communication, you need an interpreter, patient has emotional or behavioral conditions that, you know, really make it a more difficult visit, or you have a mandated reporting event that you have to start during the session. Note that fourth one, play equipment, devices, interpreter, other physical devices, or translator to communicate. So when you are requiring the telehealth coordinator to stay in the room with a patient at the nursing home, that's interactive complexity. That's making that service harder to do. The patient is demented enough to where they really are needing assistance in the visit to communicate with you. Those types of things, you should be billing the interactive complexity. And just remember to document that the patient has that situation. And most of you are good about that from what I've seen, documenting who's in the room or why you need them there. Patient's hard of hearing, patient is confused, resisting the appointment but is still being seen, those types of things. We do have that on our compensation rate. It's a whole $4. I know it's a very exciting amount, but I think it's appropriate. We should be billing it. and you should be reimbursed for that extra complexity there. And it can, and again, it can be billed with any of the therapy codes, and maybe billed in addition to some of those other situations when it's appropriate to have family present or prolonged services, that sort of thing. So don't forget about this code. Psychotherapy codes, the big point to remember here is that you need to, if you're going to include it in your med management note, you just need to state that psychotherapy services or counseling was provided and how many minutes you provided it for. In order to bill any of these codes, we have to surpass the midpoint of the minutes that are listed in the code. And so that's why I have the 16, 23, 31 at the bottom. Those are the amounts we have to, you have to see the patient for at least in order to bill these codes. I will caution you that if every time you bill the 90833 add-on code for 30 minutes of E&M with the patient, or 30 minutes of psychotherapy in addition to the E&M code, and it's always 16 minutes, an auditor is going to have an issue with that. You really should be noting actually how long you spent in psychotherapy in addition to that E&M. Now, there's no time requirement for the E&M if it's key component based, and so you reasonably could do a 10-minute 99214 and then spend 20 minutes in psychotherapy with the patient. So if it's in that half an hour visit. So if you have spent 20 minutes, please note 20 minutes. That's just a huge red flag to auditors when you have a time-based code like that conveniently you always are just surpassing the midpoint, and that's always the time that you list. So be aware of that. And I think I see quite a bit of that, especially with the 90833 or the 90832. I see a lot of 16 minutes that we've just happened to provide there. So be aware of that. So when you do use the add-on codes for psychotherapy with the E&M service, you always select your E&M level first, and then that E&M has to be key component based. We don't do a lot of time-based E&M here. We can, but if you use time for your E&M, then you aren't allowed to use an add-on code for psychotherapy. Just one or the other can be time-based. I'm going to talk a little more about key component based versus time-based E&M in a little bit. But just note that if you're going to add on psychotherapy, has to be an exam-based E&M. Crisis psychotherapy, we probably should bill a little more often when this is occurring. So this, as it says, is psychotherapy for a crisis where you're really needing to, I liken it to critical care services. You need to provide this type of care at this time, and it's the patient doesn't have to be suicidal or homicidal, but they're in some state that needs to be resolved fairly urgently. So if you end up and have an add-on visit one day because of a changed mental status or something, consider if this wouldn't be more appropriate. Note again that these are time-based codes, and so the first code 90839 is a 60-minute code, so that would be 30 to 74 minutes, and then so 31 to 74 minutes, 16 minutes for the add-on code beyond that 74. So usually you'll would use the 90839, but I would consider when maybe that would be appropriate. Obviously not very often, but I happen to know we have a Colorado patient right now that this probably is would have been the appropriate code for in some instances. Especially like if you're they're seeing you instead of going to the emergency department, perhaps that might be a good time when you would use this code, or it's affecting their ability to stay in the facility that they're at, or that sort of thing would be a good time to use this. If you have more questions about this and when it would be appropriate to use again, please let me know. Patient needs to have a life-threatening presenting problem. The assessment needs to have that urgency to it. Make sure in your assessment to include that it was urgent, that they were in a crisis state. You need to include a mental status exam and then the disposition of the patient at the end of that visit. I am only pointing out the 90863 farm management code for you to remind you not to use it. It's, before we had the code changes a few years ago in psychiatry, we had that med management code, and some providers thought that this was that new med management code, and it's not. We just use E&M now for med management. This is a very specific code that was created by CPT, and as you recall, the CPT codes are created by the AMA and the CPT editorial panel. So some of CPT includes advocacy and not necessarily regular practice or current practice. And so they created this code specifically for clinical psychologists in New Mexico and Louisiana who have prescribing abilities, and Medicare does not pay for this code. They don't allow psychologists to prescribe there. So these are sort of Medicare specific. So don't use this code. Forget that we have it. I want to talk a little bit about family psychotherapy with the patient. I see this billed quite often, and the note states that family was present with the patient during the visit. And this code really isn't appropriate just for family present. Again, that would be more the interactive complexity code if it's that the patient needs caregivers involved in care planning. This really is about helping the family communicate better or resolve interfamily conflict. That type of thing where psychotherapy is taking place as a group or the two people, whoever are there. Has to be at least 26 minutes of family psychotherapy. So if you had that 30-minute visit with the patient, you would need to be able to say that 26 minutes of that time was in family actual psychotherapy and that counseling type milieu, and that you've spent 4 minutes on an E&M. So then you're going to have a pretty low E&M. And also note that the individual psychotherapy codes may involve informants. So that also may consider, okay, well, I'm not really doing family psychotherapy, but I am doing psychotherapy with the patient, and you're getting information either from the telehealth coordinator or from a family member, family caregiver, and that's informing you as part of the patient psychotherapy. So you would include that in the add-on code for individual psychotherapy. A benefit there is that those codes only require 16 minutes, again, where family psychotherapy does require 26. And note that in the nursing home, actually, this code includes what we call the mid-management codes, the 99307 to 99310, the subsequent nursing home visits, and it also includes clinic E&M visits. It's a fairly well-paid code, and they consider that if you're going to do some mid-management, it's going to be part of that psychotherapy. So when in the past you've billed both an E&M code and this code, usually what happens is this code gets paid and then the E&M does not, and that's appropriate because the two do bundle. I did not realize that for a while because I kept looking at just the E&M thinking it would bundle the psychotherapy, and I wouldn't find it and couldn't figure out why we were getting paid, and I finally thought to look the other way, and it's the E&M is bundled here. So really consider when this is the appropriate code. We likely should not be billing it as much as we do. Some other options there: individual psychotherapy, interactive complexity, other possibilities. So that's the end of the psychotherapy or psychiatry codes. If you want to pause there, make any comments or question notes that you may have, we're going to move into the evaluation and management services section. First, we're going to talk about time-based billing. And I want you to consider when it may be appropriate to do this, when you're really spending more time in a counseling and coordination of care E&M versus an exam-based E&M with individual psychotherapy or without it. I don't tend to see our notes done this way a lot, since the templates that we have are more exam-based. And this is also where I'll be interested to have some conversations with you about how you're using the templates, how you could use the templates better, or how we might change them, what your perspective is from a clinical standpoint versus what we need to have in the rules, which for right or wrong don't always jive. So time-based billing, when time is key, when a majority of the evaluation and management service has been spent in counseling or coordination of care, when it dominates the visit. So at least 50%. So again, we're surpassing that midpoint of time. If you're interested in looking at billing more based on time, I can give you the midpoints, what we're looking for there. Or actually we have to get, excuse me, the time you spend in counseling and coordination of care has to surpass the midpoint of the service time, but then the total visit time has to be that. So for example, a 99214 is a 25-minute visit on average, they consider. So 13 minutes of that visit needs to be spent in counseling and coordination of care, but the total visit time has to be 26 minutes. So when you spend most of the visit in counseling or coordination of care and you're just going to bill an E&M, there's not an option between key components and time. Time-based billing must be used then. 3 things you have to note: the total time spent with the patient. So with that 99214, you'd say you spent 25 minutes with the patient, and in some way that a majority of the visit was spent in counseling. And there's a number of ways to say that, but it just can't say most, or it was a 30-minute visit today or something like that. We have to clearly see that majority of the visit was spent that way. So greater than 50% of the visit was spent. And this may, really consider if this isn't more appropriate when you're seeing the patient a little bit, but then also talking a lot with that telehealth coordinator, or in the clinic of the patient about where they're going to get other services or updates to meds, or talking about tapering, different things like that, where you really, less the counseling since you have psychotherapy codes you can use, but more that coordination of care element, where you're spending a considerable amount of time there. So 25 of 30 minutes was spent in counseling and coordination of care, something like that, and then a brief summary of the discussion. So this is an example. Ms. Smith was seen today via telehealth encounter to discuss her stable bipolar disorder and med management. We spent most of the visit discussing the importance of continuing to take her medications on schedule and which symptoms should prompt the patient to call for an appointment and which symptoms require immediate medical attention. Our total time together today was 20 minutes. So I think at 20 minutes, I don't have my schedule in front of me, but that's a 99213. So if it said 25, it would be a 99214. And this literally is the entire note that's required for time-based visits. So that's also the benefit to time-based visits. When you really are spending most of that time in counseling and coordination of care, your documentation burden really goes down. Obviously, if you do have a patient on meds, you're going to list the meds here and, refills and your plan and whatnot. There's going to be just a little more here. But then you don't have to go through all of that history and family history and exam elements you don't really want to do today, or copying in these elements from another note, and all of those sorts of exercises you go through in order to build this key component based note when this may be more appropriate. So again, if you're interested in this, let's talk more about it, how to write an appropriate note when it would be most appropriate in your specific practice. So now we'll talk a little bit about key component based billing. This is where we're looking at history, exam, and medical decision making. A couple of things in history to remember. Chief complaint. Every note needs one. Medicare considers that a note without a chief complaint doesn't exist. It has to be the beginning of the story. It may be the same thing that you write in the assessment and plan, but it does need to be there. Sometimes I see nursing home notes that just start with the patient is here today, Mary is here today with her sister, and Lisa, the telehealth coordinator, and they say that she's been better this week. She hasn't had any events. We don't know why that patient is being seen. Are they being sent in follow-up for med management? Is the patient bipolar? Is the patient demented? What is your reason for talking to this patient today. We need that beginning of the story. Very important piece. And that piece always needs to be documented by you. Two different ways to document HPI, history of present illness, either 4 items of the who, what, when, where, and how of the patient's disease, or current status of 3 chronic conditions. So if the patient has 3 chronic mental diagnoses or psychiatric diagnoses, or a couple or one and some other medical diagnosis that it would be germane for you to refer to, that's fine. Again, if we're going to try and get a higher E&M level with key components and use history of one of the elements, we need 4 items of HPI. We can get a lower level with fewer, but this is how you get a comprehensive or the highest level of HPI. Review of systems. So anybody can document review of systems as long as the note states that the provider reviewed it with the patient and notes anything pertinent. It can be off clinic patient intake form that the patient fills out. It can be in a note and say that it was reviewed with the patient. But a few things do definitely need to be there. You always need to specifically document the patient's psychiatric review of systems, since you're seeing them for a psychiatric issue. You can then abbreviate the other 13 as all others negative. There are 14 identified systems in review of systems. And either you attest that you've asked all 14 and you're abbreviating the rest as negative, or you need to specifically list all of them that you've asked. Some inappropriate ways to document this would be the remainder of a 10-point review of systems was negative. That's not appropriate because we don't know what 10 of the 14 were asked. So the all others negative abbreviation may only be used when you're saying that, yes, I personally asked the patient, or reviewed off the intake form all 14 systems. Note as well that the review of systems said current status and history is past status. Sometimes in review of systems, I will see more of a past history than review of systems. So review of systems is the dynamic side of a disease, and the past history is static. So if a patient is depressed, depression is past history. They've got depression. Review of systems is asking the patient, how's your depression today? Are you doing well on your Paxil? Or have you been having any events lately? It's that active piece of the patient's diagnosis. In cardiovascular review of systems, it would be inappropriate to say remote MI. That's past history. Patient has no current chest pains, or patient has occasional angina relieved with a sublingual nitro. Something like that would be appropriate. So it's that dynamic versus static, active versus passive type language. And again, something that especially Medicare auditors will really mark off. Past history, for right or wrong, you get 1 point for all of those things: past medical, surgical histories, allergies, med list. If you say you reconciled the patient's med list with them today, you have listed past history. So in all those elements, really just list what you need. Don't feel like you need to go through all those elements for some, to get points for something. List what you need there. Family history means history of disease within the family, not family makeup, not patient patient lived with her sister until she came to the nursing home or something like that. It's, patient has a living sister who doesn't show signs of depression. Patient states that mother was very anxious when she was a child, something like that. And then social history, again, any of those things gives you the point, and you just get 1 point for social history. So tobacco, drugs, alcohol, school, living arrangements, does the patient work or are they retired, family makeup, any of those things. If you say patient doesn't smoke, that's social history. So again, only list what you need. So that's history. We're going to move on to exam now. There are 2 different guideline sets that you can use, the 1995 and 1997. And 1995 really is not helpful for psychiatric providers, and that's part of the reason why 97 was built. 97 guidelines are a lot better for very focused specialties: psychiatry, ophthalmology, hand surgeons, where you're really focusing much more closely either on one specific body part or on one specific system. So a comprehensive 1997 exam requires all of the bullet points listed on this page. Again, similar to that comprehensive exam that was required for a diagnostic eval. Constitutional, you need to have both general appearance of the patient and any 3 of the following sub and vital signs. Again, number one thing I see missed is that musculoskeletal element. You need one or both of those, either assessment of muscle strength and tone or exam of gait and station. And then all of the listed psychiatric elements: speech, thought processes, associations, abnormal or psychotic thoughts, judgment, orientation, memory, attention span or concentration, language, fund of knowledge, and mood and or affect. All of those things need to be listed in order to be comprehensive. The next step down from comprehensive would be any 9 of these bullet points. So either all of them, or then 9 is where you get to detailed, and then just 2 would be an expanded problem focused, or 1 would be problem focused. So we're either either trying to get, and mostly I think you're really doing either a comprehensive where you get all of these bullet points, or that 9 point. I have an example. This is an example I pulled some months ago out of a note. And there are a number of things missing from this note. So you'll see, hopefully you have your screen in color, and you can see that there are both green and black X's. So you'll see that I've marked 5 items on this. There are only 5 bullet points from this templated note that I pulled from Valent that would count towards that 97 exam. So we have appearance, appropriate dress, and so, you know, adequate grooming and hygiene and assistive devices, that all adds into that, but a point is a point, you don't get more. There's no behavior element in exam, so that doesn't count. The speech element counts because the poverty of speech is further described. Note below with thought content that it's just that the patient is abnormal, that they're delusional. We really need to know what's happening there or how bad they are. When a patient is normal, such as with mood, you can just say they're normal. But any abnormal exam needs to be further described and unique to that patient. Medicare also came out pretty strongly in 2012 and stated that when they see templated notes used over and over again and only marked and additional comments not made, that they will often find those not to be a unique note to that patient and will disqualify that portion of the note. So anytime the patient has an abnormal finding, you really need to make sure to list that. So let me walk through more of this. Mood gets us mood. Affect was already credited under mood. As I said on the last page, that one bullet point had both mood and affect. Thought process is noted. Thought content, abnormal or psychotic thoughts is counted. I'm sorry, I meant before that insight and judgment is what is not, it's sort of listed as abnormal, but we don't really know how. Poor insight into what, why, how is the judgment impaired? We need more information there. Consciousness has no element on the exam. Orientation, again, no credit because it only states the patient is impaired with no additional information. And then recent memory and remote memory, again, it states they're impaired, but we don't know how. And then completely missing from this template were the associations. Attention span and concentration, language, fund of knowledge. It said that the vital signs were reviewed, but there was no documentation of the vital signs within the note. And I know we have it within Valent, but we need to make sure that whatever we would give to Medicare or to an auditor includes that information. And so it would be better if you say reviewed, see the vital signs page. And that's something that we could put in the template, I think, that we're able to change. And then again, that assessment of muscle strength and tone or exam of gait and station, the musculoskeletal is not included here. So what may be included in this template are the really important things to you as a clinician, but in order to get, if you feel like if you are providing and asking these other elements and providing that 99214 or 99215 level of visit, we need to document more of the visit that was performed. And so again, perform an appropriate visit, accurately document all elements of that visit, and then select the code that most appropriately represents that documentation. So if this template really does accurately represent the visit that was performed, we only have 5 elements selected, not 9. So this would be an expanded problem focused exam. So 2 steps down from the top, and it would support a 99213. So very important to make sure to document all pieces of the exam. And I'm sure you'll want to talk to me more about that. Let's have some conversation. We also should look at updating our templates in ways that make sense to you clinically, but then also capture these other elements if you are in fact performing them at your visits. If you're not, then we need to look at, okay, are you doing at least 9 bullet points at your visits, and is it appropriate to use a detailed exam, which is still a 99214 level exam? That would be fine, but we need to make sure that all 3 of those pieces are matching up. Visit performed, accurate documentation of the visit, appropriate code for the documentation. So then the third component is medical decision making, and if you thought that the exam portion was confusing, get ready. Medical decision making has 3 elements, and it can be a little confusing. So I'm going to try to simplify it for you based on the actual patients that you see, but we'll just do our best. Oftentimes what happens is I have an individual conversation with the provider, and we determine typically this is the type of patient you see, and here's how to score the medical decision making portion. So number of diagnosis and treatment options, data review, and table of risk. This is a little cutout of the audit tool I've created that has those 3 elements on it. Note in the top, diagnosis and treatment options. When you are seeing a follow-up patient who has 1 psychiatric diagnosis you're seeing them for, and they are stable or improving, you get 1 point for that. If they have an established problem that's worsening or not improving, that you're having to do med changes, you get 2 points for that. And each one of those problems that you are going to assess, that you are diagnosing or that you are treating, or that significantly affects the patient's care, can be included here. But then they also should be included in your assessment and plan. A patient with dementia that has a resolving pneumonia or something, you're certainly going to want to include that, because you're having to include that in your diagnostic process and the treatment options that you may choose. New problems are either 3 or 4 points. So when you're doing a diagnostic eval, if you were doing a new E&M, or if the patient has a new problem that comes up during a follow-up patient or follow-up visit, you certainly can choose those. But you'll see later on when we add all of these elements up that having just that one established problem that's stable is not supporting the levels maybe that we're billing. And so either if the patient has more issues that you're addressing that need to be documented, then you should, or being clear about if that patient is stable or improving, or worsening or not improving. Second element is data to be reviewed, so always make sure to include, did you, review any labs? Did you order any labs today? That's a big one you may use, as well as the second from the bottom, the 2-point review and summary of old records and or obtaining history from non-patient and or discussion of case with another provider. That and or obtain history from non-patient, when you're having to collect information from the telehealth coordinator or from a family member, then certainly then certainly you would have 2 points there. So 1 to 3 points often in the data. And then the third element is the table of risk. And the patient can be minimal, low, moderate, or high on the table of risk. So this is the table of risk. We look at this. This is not comprehensive, and we need to find something on this table from any of the columns. And we can go to the highest level that the patient has. So I've circled over on the right prescription drug management. Anytime that you are managing a patient on a prescription drug, and that means a real prescription, not the 800 milligram ibuprofen type things, but actually they have a drug that must be prescribed, and you're managing that in some way. It's either a new drug, a drug you're changing, you're DCing a drug, you're deciding to keep the drug the same, you're making some prescriptive drug decisions. That puts the patient into moderate risk. Other elements that also are in moderate risk are if the patient has 2 stable chronic illnesses or 1 chronic illness with mild exacerbation or progression, so 1 non-stable chronic illness. So I think a lot of your patients are going to fall in there. That puts the patient in moderate risk. High risk would be 1 or more chronic illnesses with severe exacerbation or progression, or an acute or chronic illness or injury which poses threat to life or bodily function, which includes psychiatric illness with potential threat to self or others. So if you have that level of patient, they are definitely high risk. Also note in red the drug therapy requiring intensive monitoring for toxicity. So if you have the patient on some type of scheduled drug where they're needing regular labs, that would also put them into high risk. We need it noted that they're getting those regular labs and that you're monitoring those to be sure that they're at a therapeutic level. So typically you're going to get at least to that moderate risk since you're typically prescribing for your patients. So this is the medical decision-making grid. And so as I talked about on the diagnoses on that first little grid, if you have 1 stable diagnosis, 1 stable established problem with the patient, that's 1 point. If you only review labs that day, that's 1 point. And so that's in the 0 bucket, not 2. That data 0 to 1. And then the patient has moderate risk. We have to get 2 out of the 3 elements here to meet the medical decision-making level. So we drop the lowest score. So we would drop either diagnoses or data. We drop one of those, and then we select the next lowest score. So since we have 2 scores at straightforward, we would score that. So even though you had a patient who's on a script, they've only got a straightforward medical decision-making. Now with established patients, we only need 2 of the 3 key components to meet the requirements for a level. So with the history, exam, medical decision making, of those 3, we have to have at least 2 of the 3 at the level, at the minimum requirements for the level. So I'm going to show you a couple of examples here of how that might not be working the way we would want it to now. So we're going to select a level. So on the left, I'm not sure. Hopefully I hope my mouse records with this. On the left is an established office visit in sort of the green grid in case my mouse doesn't show up. If we had that patient with the comprehensive history, because you went and did all those pieces that we listed at first, you had a chief complaint, and then we had that existing templated exam was an expanded problem focused, and then that patient with 1 established stable problem, and you looked at labs, and even though they are on a prescription prescription drug. It was straightforward. Again, we're going to drop that lowest score and go with the next level. So based on those examples I showed you, that visit would be a 99213, not a 99214. Similarly, over here with a subsequent nursing home visit, I circled the detailed history here instead, but we could have circled comprehensive. Again, with only the expanded problem-focused exam and the straightforward medical decision-making, that's a 99308, not a 99309, which is what we usually bill. So one of those, either the exam or the medical decision-making, needs to be better documented to reflect what you actually did in the visit to get to that 99214 or 99309 level. Again, 9 bullet points off of that exam would give you a detailed, and any 2 of these 3 are fine, meet the requirements. So if you bumped up the exam, that would be, and more accurately documented the exam based on your actual visit, that would suffice. And or then you also then get up a level quickly if the patient has a new problem or they have multiple problems that are stable, or maybe one stable problem and one unstable problem, or one problem where things are going well but maybe you're going to adjust a med on a second diagnosis. Something like that would also get you up to the moderate medical decision making. So we need to either see exams at detailed or medical decision making at moderate in order to get to those higher levels. So here are some examples of what that looks like. Before I move on though, let me note for the nursing home folks, a 99310, you'll see we have 4 levels we can bill for the subsequent nursing home visits, aka med management checks. 99310 is the highest level, but the patient needs to has to either be unstable or have a significant new problem requiring immediate attention. So the patient needs to have some urgency there. But if that's occurring and you have 2 of those 3 elements, comprehensive history, comprehensive exam, and or high risk medical, high complexity medical decision making, then you can get to that 99310. It's just that urgency is an extra element there that needs to be documented. So here's what it looks like if we would move those exams up to a detailed. Then again, we're going to drop the lowest score. We would drop the medical decision making, and that would move these visits up to a 99214 or 99309. Again, don't need a comprehensive exam. It would just be getting 9 of those elements that are on the page. I think it would be easy to add a note about vitals. That would have gotten us to 6 on that exam. Examination of muscle strength or tone would be 7, gait and station would be 8, and then just 1 more actual psychiatric bullet point and we would be at 9. So always remember, some of those things that you're assessing that you don't have to touch the patient for, you still can get credit for. If a patient has labored breathing, you would certainly write that down. So if you note that their breathing is normal, you can document that. Not a bullet point on your exam, but that was an example. So if you would note, oh, the patient is much more hunched over in their chair today and appears weaker, then if they don't appear more hunched over and weaker than they usually do, document that. So those normal visual exams, make sure to include those because you're doing them and they often are what you need to get to that appropriate level. So here's what it looks like if instead we would move the medical decision making. So if we left the exam the way it was but moved medical decision making up. So remember, we had prescription drug management on the table of risk. So then we just needed either better data or better diagnoses. If you'll recall, in data, if you look at labs or order labs, that's a point. And if you get history from someone besides the patient, that's 2 points. So if you're talking to the telehealth coordinator in the nursing home or a family member for history, and you note that, that would be an extra, that would be 3 points. That would get you to a moderate. And or when you have a patient with multiple diagnoses, then that often gets you to a moderate. So again, I want to emphasize, I'm not really asking, and I don't really think that this is going to cause you a lot more documentation. I think it's just more about documenting what you actually do, making sure to put it all down, and then documenting maybe in a smarter way. So that's the end of the evaluation and management services section. Again, if you want to pause for a couple minutes and write down any comments or questions you have for me to follow up, that would be great. A note on frequency for nursing home providers. Subsequent nursing home visits, so the 99307 to 99310, we often bill a 99309. Those can only be billed once every 30 days via telehealth to Medicare. It's a quirk of Medicare. We don't know, I don't know why they did it. I guess, there was some thought of course, more with, internal medicine, they should be seen physically if they need to be seen more than once every 30 days, and doesn't really take into account the type of work we do. So if you need to see the patient more often than 30 days, you have two options. And I'll back up just a moment to say it literally is about those subsequent nursing home CPT codes. If you do a diagnostic eval, a 90792, which is a psychiatric code, and then see the patient 3 days later in follow-up, you can bill your subsequent nursing home visit code. That's fine. It really is about that set of 4 codes and being able to send those in only once every 30 days. So the diagnostic eval is outside of this. So you see a patient, you need to, for a follow-up, you need to see them 2 weeks later, maybe you've changed a med. There's 2 options. One, Medicare created a code since they specifically figured out, psychiatric providers may need to see patients appropriately via telehealth more often than every 30 days. And so we have a specific HCPCS level 2 code, this G code, G0459, and it takes the place of your subsequent nursing home visit. It is specifically a code for inpatient telehealth pharmacologic management. So you need to be doing med management that day, and so actually the patient can be in a skilled nursing facility or in an actual inpatient acute hospital setting to use this code. So you'll want to look at that for those visits. Or if you are doing a psychotherapy visit with the patient, you certainly can bill an appropriate psychotherapy code, standalone code for the 30, 45, or 60 minutes. Those are fine as well, but then your note needs to reflect that it was a psychotherapy visit and not a med management visit. If the note is really written up as a med management visit, then Medicare audits, they're going to want to see that G0459. Talk a little bit about Region 3 for the clinic providers. We're moving to how we're tracking the units for Region 3 in our system, because we use a CPT equivalent code to bill Region 3, but we actually don't, or to track Region 3, but we don't bill them with those codes. And so all of those key component rules and the time-based rules, all of those things don't apply to Region 3 patients. We bill them on 15-minute increments at how many units there are, 1, 2, 3, 4, 5, 6, however many there are. You have to surpass the midpoint of the time for each unit, and they are 15-minute increment units. And we cross-reference to the CPT codes for tracking and reimbursement purposes only. And so 1 unit that's billed to Region 3, we consider the equivalent of a 99213. And so those 1 unit and 99213s are bundled together for your compensation. Note that that's an 8 to 22 minute visit. Again, I caution you to not always conveniently have 23-minute visits. That would be a high risk area in an audit, that we were gaming the system and just getting that extra minute in order to bill that second unit. See the patient for the appropriate amount of time that's clinically required to see that patient for. Document that accurate time, and then we'll choose units based on that time. Prolonged services. We kind of go back and forth on having some prolonged services billed. So prolonged services are add-on codes to evaluation and management services only. They are for outpatient. They are outpatient and inpatient codes. So the clinic folks would use 99354 and 355. Inpatient would use 356 and 357 in the nursing home. And again, they're based on time. These codes can be used with any other CPT code. So let's say you're billing a 99309 based on the history and exam, and I'll show you an example of this on the next slide. But it takes a lot longer to do some portion of it, you know, because that interactive complexity with the patient. It takes you an extra half an hour longer than you normally would spend to take the person's psychiatric exam, let's say. So then you could bill these. These codes all require direct patient contact. These are not, this isn't for time spent without the patients, so be aware of that. And there are, I've listed over here, if you would spend inordinate amounts of time with a patient, how to bill. Typically, you're going to just surpass that 30-minute point, and it would be a 99354 or a 99356, depending on the setting. So if you're going to bill prolonged services time-based, you can only bill them on top of the top level service in the list of codes. So you would bill it on top of a 99215 or a 99309 and the time listed for those codes. 99215 requires 40 minutes. So in the clinic, you could bill prolonged services then once you saw the patient for 70 minutes. Otherwise, you can do that key component-based visit like I described before, where, so let's say the patient has a lower history because patient's confused or not quite oriented, and so it's taking you longer to get that information from them, and it's an extended amount of time. If you're not using these codes and you'd like to explore using them, please let me know. Again, we can have some discussion about that. Finally, I have a couple of behavior change intervention codes I want to point out to you that you may be doing and maybe not, but you may be doing and we maybe could be billing for when they're appropriate. So the first code is smoking and tobacco use cessation. If you're discussing this with your patients and you document the time you spend talking to them about it, then that could be billed and you could be compensated for that time. And we do have 99406 on our compensation schedule for $5 for the 3 to 10 minute session. So we could add 407 if you did that. But so certainly if you're doing this and you are comfortable saying you spent 5 minutes or 4 minutes or however long it is, certainly include that in your note and add that to the CPT codes that we're going to bill on your appointment so that we can add that in. We'll also then need a tobacco abuse type of diagnosis code to go along with that. There's also alcohol and substance abuse screening codes that can be reported separately, again, based on time. 99408, and with these, you do have to actually meet these times. And 99408 is 15 to 30 minutes, and 99409 is greater than 30 minutes. It's using a structured screening of some kind and then a brief intervention service about alcohol or substance abuse. And then that's documented in their note, and then that structured screening form is also saved into the system. So if you're doing some of that, maybe more at the clinic, maybe certainly let's talk about making sure to get those codes onto your charges as well. So that's the end of what I have for you. I'm looking forward to your questions and having some good discussions with you. As we talk, I will probably not make big changes to templates or anything like that till I feel like I've talked to as many of you as are interested. So then we can make some agreements about some changes to make. I'll also try to set up Then depending on the feedback I get, I'll try to set up a follow-up to this maybe in about a month where I can go over questions or clarifications, that sort of thing, that came in. Thanks all for your time. I hope this was helpful. If there are other topics you would be interested in hearing about, or topics you'd like to hear about more in depth, please let me know. I love to do teaching and training. It's a real passion of mine, so I'm always happy to do this piece. Also, I have on my list for this year, hopefully by the end of June, to get everybody a good audit and some feedback on that. I'd like to maybe get some of these changes implemented for existing providers and then do an audit, since I know we have some concerns now. And then as new providers come on, I'll start getting incorporated into my process to do a new provider audit for you as well. That has been on my to-do list, and hopefully I'll get that done soon. So you have a great day. Thanks for listening, and thanks for being part of Encounter.